Mission and margin is the business of healthcare. I'm your host, Matthew Hannes, founder and executive producer of the Business of Healthcare. In this BOH episode, we interview Cigna Senior Medical Director Dr. William Lopez. He and his colleagues have proven patients with behavioral health diagnoses incur 2 to 3 times the medical expense as similar patients without those conditions. Now the team is helping their network of providers fund the integration of behavioral health services to prove that they can lower overall costs by making these services available. This effort is significant because Cigna's members primarily come from commercially insured large employers.
If you manage behavioral health in medically complicated patients, you're going to have better outcomes and better control of costs. And we have seen that in academic settings, we have seen that in Medicaid programs where they have grants and funding. But what we're looking at is, can we produce the same outcomes in a commercial book of business? Can we replicate that and provide the quality of care and the total medical cost improvement that we have seen in other models?
Our thanks to Foothold Technology, New Directions Behavioral Health, Raven Healthcare, and VPAC Clinical, which together made this interview possible. Dr. William Lopez is Senior Medical Director for Behavioral Health at Cigna Healthcare. In addition to his responsibilities, Lopez leads work integrating behavioral services into Cigna's provider network, as well as leading enterprise-wide national telehealth strategy and many initiatives responding to the opioid epidemic. Lopez has served as a staff psychiatrist and medical director for healthcare providers and also in the U.S. Air Force, where he practiced aerospace medicine and is a Desert Shield and Desert Storm veteran. Dr. Lopez is a certified physician executive and is board certified in psychiatry. Dr. William Lopez, thank you so much for joining the Business of Healthcare today. So you have a really interesting background. Tell me a little bit about how you ended up in psychiatry.
Well, yes, I started my career, or my medical school in Puerto Rico, and then moved to the United States for my training. During that time, I joined the Air Force. So I was a flight surgeon for the Air Force, and I worked with pilots. And as I was working with them and their families doing primary care, I found myself talking about their issues, their problems, their depression, and kind of gravitated toward behavioral health, to looking at some of the mental health issues that many of the people I was talking to had. So eventually I decided that maybe this may be a calling for me. So I pursued psychiatry and went for training, and I trained at UCSD, University of California, San Diego.
And you served in Desert Shield and Desert Storm.
Yes.
And thank you for your service.
Thank you.
That experience probably impacted your views of behavioral health and treatment.
So I did work with a lot of veterans from prior conflicts and from more current conflicts, and I did see firsthand the struggles of mental health issues in our military and our veterans.
And now, fast forward today, you lead behavioral health as a medical director at Cigna, and also have responsibility for virtual health and
yes,
some of the virtual health initiatives. Talk a little bit about your role at Cigna.
So I have been with Cigna for 12 years. Cigna Healthcare is a global health service organization dedicated to improve the health, sense of well-being and security of our customers. We have a presence in about 30 countries around the world and about over 95 million customer relationships. So we're very broad in our reach around the world. My role individually in Cigna, I have been working for the last few years as the lead medical director around our virtual solutions for both medical and behavioral health. I also spend a lot of my time working on enabling integration of behavioral health in the primary care setting, and I have work that I do in some of the initiatives that Cigna has in response to the opioid epidemic.
So Cigna serves 15 million lives in the U.S. Talk about the services that are provided.
Cigna's services are very comprehensive. We have Cigna Pharmacy, Cigna Disability, Behavioral Health, Medical. We also own HealthSprings, which is the Medicare Advantage book of business, and we have a presence in 17 states through Medicare Advantage programs.
Cigna as an organization, if I understand correctly, is, I would say, a little bit more mature in the idea of not bifurcating the handling of behavioral health services versus that of other medical services. Would you say that that's the case?
That is correct. So we're looking at it both internally and externally. So internally, we're moving to a place where we are both behavioral health and medical work in the same platform, so we can communicate and share better information and look at our customers in a holistic way. Externally, we're enabling and trying to promote integration of behavioral health services in the primary care setting as well.
And that process of I use the term bifurcation because in many of the health plans that I have experience with, the medical spend ends up in a different bucket than the behavioral health spend. And so you get into a situation where good-spirited people trying to do the right things have an economic incentive to not necessarily optimize the blend of behavioral health and medical. I would imagine that was the case in the past at Cigna, because most health plans are like that. What was it that changed culturally?
The understanding that the value is on looking at the customer in a holistic way. You cannot just treat medical and behavioral health independently. You have to look at the whole picture. If you look at a lot of the data that we have more now in the last 5-10 years, there's more and more evidence that when you address behavioral health issues or medically complicated patients, they do better, and eventually you get to have a better total medical cost.
And you've actually advanced to the point where you've proven the first piece of that by applying the Milliman methodologies to your data, improving. Well, tell me a little bit about that work.
Yeah, so we apply the same methodology to our population, and lo and behold, we found that our customers with complicated medical conditions that have comorbidities that are behavioral health based are indeed 2 or 3 times more expensive to manage overall, not just behavioral health, but all the overall medical costs is 2 or 3 times higher than for those that do not have the behavioral health diagnosis.
The population that Cigna serves, what's generally the nature of your members?
The membership. Cigna is a national employer company. We insure large employers around the United States, like ExxonMobil, Disney, and such. We also have other products, and we do have employers that are in mid-markets that are like 5,000 under employees. So we have a broad variety of products to help all different employers, but our bread and butter is the large national employers.
You did the analytical work to validate this relationship between behavioral and complex medical conditions. What did that lead you to? If
you manage behavioral health in medically complicated patients, you're going to have better outcomes and better control of costs. And we have seen that in academic settings. We have seen that in Medicaid programs where they have grants and funding. But what we're looking at is, can we produce the same outcomes in a commercial book of business? Can we replicate that and provide the quality of care and the total medical cost improvement that we have seen in other models? You're recognizing that the research, which tends to be in populations around academic medical centers, Medicaid, elderly, the question became whether that evidence holds true when you're looking into a commercial population, which Yes, and how to make it sustainable long-term, how to make a model where the provider can be reimbursed for many times the work they're already doing. They're taking care of these patients that come in with complicated medical conditions and depression, anxiety, and they have to do some of this work, and they don't get reimbursement for that, and they don't have the ability to fund the resources to provide a holistic approach for the customer. So your effort here being to try to align those economic incentives such that the physician has the resources to serve that patient in the best way possible, both clinically and financially. Yes, so what we're currently doing, run a pilot based on the collaborative care model. This is out of the University of Washington Ames Center, and following the guidelines from the CMS rules that were released last year to reimburse providers for integrated services, where we expect them to have a structure where there's going to be a behavioral specialist that's going to coordinate care. They're going to maintain a registry of all the patients that are enrolled in this program, and they're going to have access to a consultation by a psychiatrist. So that will enable them to provide a holistic approach where they can not just manage the hypertension or the diabetes, but if there's a complicated depression or anxiety, they can feel that they can manage it at home. The issue is that for many providers, you have a patient that walks into your office and you start talking about depression, they may do the screening and they may talk to you, but they may not know what else to do. I mean, they may not have the resources. So if you have a structure that will allow you to steer this patient to the right care, it could be that you decide to manage it yourself with some support from a psychiatrist, or to refer out, you have that ability. But right now, it's not there.
Talk a little bit about the population that's in this pilot.
So we're partnering with 8 of our collaborative care partners. These are the private sector version of ACOs. Okay. And we have picked them up because they have interest and they have some motivation and actually some experience with integrated care. And we're enabling them to build for these codes. And we're also supporting them build the structure around them. So they're able to hire a behavioral specialist to support the model. And we're providing some analytic information so they can take action on some of the reports that we get. And we are looking at how we can, again, make this sustainable and make it a long-term opportunity for them.
And taking the codes from CMS would seem extremely convenient. As the provider, you're giving them essentially the same rules that they have to do in a Medicare population.
Yes.
And so the codes go into place. The providers have gone into this pilot sort of knowing what you're pursuing. How hard has it been to engage them and them engaging culturally into an integration model?
Yeah. The problem has not been so much engaging them because they want to do this, and most provider groups, larger groups, they recognize the value of addressing behavioral health in primary care. The challenges have been about building the structure, about the requirements for these pilots. And in some ways, yes, changing the culture in the office. You cannot just be the provider saying, we're going to do this. You have to get a buy-in from your practice, from the front desk to the nurse assistant. Everybody needs to understand that we're doing business differently and that we're looking at behavioral health as part of the work we do every day.
A PHQ-9 is sort of a vital sign, just like heart rate and blood pressure.
Yes, correctly. We have we have to normalize the management of behavioral health in primary care setting, just like we do for diabetes or hypertension.
So what happens next? So you've got a population, 200,000 lives.
Yes.
The study has begun, and what happens next?
So we just have started to have some experience getting some of these patients or customers going through the process. So it's very early to get outcomes right now, but some of the things that we're doing to support the practice, we have a dedicated Cigna care coordinator that works with the practice and the practice behavioral specialists to help answer any questions and address issues with contacting customers and getting them into the system. We also are providing analytics. We're looking at data and trying to predict which customers behave like those that have a diagnosis but they don't yet. Mm-hmm. So we're looking at ER utilization, pharmacy utilization, admissions, and we'll tell the provider, here, there's a number of patients that behave as someone that may have depression, but they don't have the diagnosis, but everything else point to that. Screen them and see what happens. Maybe we can find an opportunity to help them.
So one of the competitive advantages that Cigna brings is a decent percentage of your clients are engaging you both for medical as well as behavioral health. How big of a portion of the population is that?
Our commercial population is about 50 million members, and over 80% are in a model where we offer both behavioral and medical services benefits. And that's kind of the premise of what Cigna likes to position our customers in a model that is holistic and comprehensive. So it is not just medical behavioral, but also pharmacy benefits. So we try to have them in a way we can have a more integrated experience, provide us with an opportunity to have data that is more actionable because we have all these pieces of information that we can work with and provide feedback to providers. So we that is our preferred model, and actually that's one of the products that we offer client groups, the integrated behavioral, medical, and pharmacy product.
And from the client's perspective, is that, do you find the market demanding that? Is the market ripe for coming up, for accepting that solution?
Yes, we are there. I think that there's a lot greater recognition of the need to address behavioral health in primary care. We have a great network. For most payers, we have providers that do evidence-based care, they take good care of diabetes, hypertension. However, we still have patients showing up to the emergency room in diabetic ketoacidosis or hypertensive crisis. And what is the missing piece here? There's something we're not addressing related to behavioral health and also some of the other social determinants of health.
So your initial work in validating the spend, where you had co-occurring chronic and behavioral health, that work was done inside. That was analytics that came within the organization.
Yes, that's correct. Again, we use the same rules and attributes that were used at Milliman and applied to our population. And we did expand too because we have other points of data, like we also have Cigna disability. So we have disability information for many of these customers. So we can add to the picture and have a more broader perspective of the customers. So we follow the same methodology. We maybe expanded a little bit. And like we talked before, we found the same outcome, which is what we were expecting.
Well, talk about how disability fits into this. What are your hypotheses there?
Well, as you think about all the social determinants of health and all the factors that impact a customer, you have customers that may have some issues that may have required disability. So you want to add that as a risk factor to their overall picture.
So in other words, as you sort of gather the data elements together, for example, that might be a data element that tells you, oh, possibly an undiagnosed behavioral health condition here.
Or possibly someone, they suffer a disability, had to be out of work for a while, someone that may be at high risk of developing depression.
Got it.
Or, yeah.
So why not intervene early and do all the things to be proactive, preventing it from worsening? So you could get good at proving the financial model. You've got the platform of integrating all the services together. Perhaps get good at detecting undiagnosed behavioral health conditions. What happens in the future to optimize the treatment? Well,
so our intent is to eventually roll out these codes for all providers so they can benefit. But the solution here, the long term, what we want to see is that their providers are able to implement all the aspects of integration that are required or that are expected to have the good outcomes. So how can we help providers feel comfortable on managing primary care, mental health conditions in primary care setting, hiring someone knowing that there's some reimbursement mechanisms that will allow to support that position, and how they can maximize that FTE of a behavioral specialist. So long term, I think that we want to see this becoming more of the standard of care.
Yeah. Dr. Lopez, thank you so much for joining the business of healthcare.
Thank you, Matt. I really appreciate the opportunity to be here with you.
To watch, listen, or read other BOH interviews, visit bohseries.com or search Business of Healthcare in our red logo wherever you listen to podcasts.